This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast also offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. So this week, we are going to be discussing the efficacy of sublingual and injectable buprenorphine on patients who are using fentanyl. So, John, how are you doing tonight?
Well, I'm doing pretty good, although it's almost 10 o'clock. I had a clinic day today. We've been fighting with technology here the past 30 minutes, and I'm a parent with 3 young children, so this is like way past my bedtime.
Well, I'm sure our audience appreciates the late night podcasting. And if things go a little off the rails, everybody, we're sorry.
I feel like I should have been born at like 1935, where like there was no technology. But anyway, here we are. How about you?
I'm doing very well. John, is there anything you want to share in addiction medicine this week with our audience?
Yeah, I saw this interesting article from Stat News, and it's called By the Numbers, America's Alcohol-Related Health Problems Are Rising Fast. I think especially I noticed this when I'm in my inpatient rounds. I feel like alcohol-related hospitalizations are very common and a huge cause of morbidity and mortality in the United States. This article kind of talked about kind of post-COVID trends, and basically some of the key points, they talk about how there's been increasing alcohol consumption. And they talk about this period of 2019 to 2021 being the greatest 2-year increase of alcohol consumption in the United States since 1969. They also talk about how since 2000, so kind of again, this post-COVID era alcohol consumption, there's been a steady increase in alcohol-related deaths. Clearly, number one, we know liver disease is probably what most of us kind of think about. But actually, number 2 followed by that was kind of actually mental health related kind of illness and kind of death from mental illness, which they do attribute to alcohol related consumption, followed by heart disease. And interestingly, they were talking about kind of these other figures, talking about how, especially younger patients and our younger population are kind of disproportionately affected, with 1 out of 5 deaths in the age range of 20 to 49 being due to alcohol, accounting for approximately 45,000 U.S. deaths per year. So that's pretty high. And I think the interesting thing that they talk about too, which has been a theme with some of our previous articles, is that they talk about the debate about what is, or is there even a safe level of alcohol consumption at all? And they were actually discussing that it's possible that the upcoming dietary guidelines for America is going to probably be updated in 2025. And they're reevaluating whether or not they think that they're going to place a kind of disclaimer about kind of no alcohol consumption being kind of within the normal limits of safety. Mm-hmm. So I don't know. Do you see kind of increasing trends? Are you more aware of this now? Or how do you feel that kind of alcohol use is kind of impacting the health of your patient panel?
It's so hard to say because so many of my people are struggling with stuff that will kill you kind of quicker than alcohol, like opioids, but I feel like alcohol is entering the conversation more. I mean, you and I must be on a MyMeld because I was just looking up statistics on drug and alcohol deaths in the U.S. also for a lecture I'm writing, and I was pretty shocked by the number of alcohol-related deaths, especially from things like suicides and other mental health concerns. So, I mean, alcohol has a huge impact on my patients, and it's in some ways a little harder to address than something like smoking or opioids because it's very easy just to say, all tobacco is bad, no smoking. All opioids are bad, don't use them. And there's very few people who use them sort of at a low level, but tons of people use alcohol recreationally at a safe level, even if it's not a health-giving activity. It's just something people do that's not the best for them, but they really enjoy. So it's the recommendations have to be a little more nuanced. But I can't say I'm seeing it more just in my personal panel. Do you think you're seeing it more sort of personally in the patients that you see, more alcohol-related harms?
It's interesting. A lot of this comes up in my non-kind of addiction medicine population. I feel like when we talk about kind of alcohol consumption, it's quite appalling kind of what people think is kind of healthy consumption. I still have lots of people who don't identify as having a problem that kind of drink on a daily basis, kind of in excess of 10 alcoholic beverages and feeling that that's kind of normal. And I don't know, like this mirrors what I read a lot in I'm also kind of in like a junior administrator at our institution, and I feel like I read a lot about health literature now, and this kind of mirrors national trends, these kind of diseases of despair, right? Kind of rising alcohol use being a reason for our kind of declining mortality rates or declining life expectancy in the United States.
Yeah. I mean, I know you're on a crusade to help people quit drinking if they want. I've been addressing it a little more forcefully over the past year as well. And, I think patients actually are getting the message that alcohol overall is bad for you. I don't have very many people anymore saying, oh, shouldn't I have a glass of red wine a day? At least that's kind of fallen away from the popular culture.
Correct. How about you? What have you been thinking about?
So I saw something that was really pretty mind-blowing to me, and I don't know when this episode is going to be released in a few weeks, but I just saw this yesterday when I was looking at my emails that the AMA, which is usually pretty conservative, they just put out a statement supporting drug decriminalization. And this just really struck me because usually, as I said, they're pretty conservative, and this is considered a pretty radical position to decriminalize sort of small amounts of drug possession for personal use. Now, not everyone in the AMA Board of Governors voted for it, but it passed by a pretty big margin. And specifically what they voted for was their support for the elimination of criminal penalties for small amounts of drugs for personal use. So, John, what do you think about decriminalization of small amounts of drugs?
I mean, I think that it kind of makes sense. I think per capita, I think the United States has the highest incarceration rate with, I think it's 51 or 52%. It's more than half are kind of nonviolent drug-related offenses. High recidivism rates with kind of just our classic kind of punishment and tough love type philosophy. I look at this as kind of like societal salvage, right? I think that kind of treating this like a criminal offense and not a medical issue, and kind of treating this with kind of harsh punishments instead of kind of engagement and treatment, I think it's not good for anyone, right?
Well, it's not good, and it just isn't working. The war on drugs has cost us over $1 trillion. And, some people say, well, the drugs are still winning. Like every year, more people die from drug overdose. So the drugs are winning the war on drugs. And if we spent like $1 trillion on drug treatment, $1 trillion more dollars, whatever we're doing is definitely not working. So I don't think drugs are good. And I don't think you should be able to buy, like fentanyl in the store and just use it however you want, methamphetamine. I don't think they should be legally sold, even if it's regulated, but it doesn't really help the patients to put them in jail. It just makes everybody's life worse, and it costs a ton of money for us. So, I'm glad the AMA support this kind of decriminalization. Something that's interesting, though, and I'll put a link in the show notes, there was a really interesting article in the New York Times where they interviewed the mayor of Portland, because as you know, Portland, Oregon had decriminalized drugs, and then they recriminalized it, feeling like that experiment had not worked. And there was just a great interview with the mayor talking about that decision and sort of the pros and cons of what they'd done and why it failed and what he thought went wrong with their experiment of decriminalization. It was really interesting. So I'll put that link in there too, because we did try it in Oregon and it sort of quote unquote didn't work in that overdoses went up when they were decriminalized, but it's not clear that that was because of the decriminalization or just because of the massive entry of fentanyl into the illicit market, coupled with the fact that they didn't do anything to actually increase treatment.
Yeah, that's interesting. I feel like, something that has to change here. The problem that becomes with this, though, and I think everyone kind of philosophically, probably everyone listening to this philosophically aligns with this. It really becomes very arbitrary, though, like where is the end of like the decriminalization and where does it kind of switch into like a criminal act? I think that's the part that I think most people struggle. And I think that's almost like a moral compass type thing. Like, what do you think is within the spectrum of kind of like drug use behavior and what's kind of not acceptable? Like, I think most people would agree if someone's using and kills someone, there's a penalty for that. But then vice versa, someone walking down the street with an ounce of marijuana that they don't have a card for, that probably doesn't worry, like it would warrant jail time. But where in the middle is the line?
Well, sure. And you'll have to draw a line somewhere. You have to make some choices, but so many people are incarcerated and basically their lives are ruined temporarily or sometimes permanently for really just using drugs and doing things to use more drugs. They haven't hurt anybody. They haven't committed crimes. They haven't stolen anything. They haven't hurt anybody. They just had drugs, used drugs, sold drugs, bought drugs, carried drugs around,
Yeah,
So
it's interesting. I'm sure it's coming, right? I think we can't keep on this current path.
Well, it hasn't worked. It has not worked. So we need to do something else. So, John, are you ready to tell us about your article tonight?
Sure. So this is a kind of interesting article from JAMA Network Open from June 2024. It's called Extended Release Injection versus Sublingual Buprenorphine for Opioid Use Disorder with Fentanyl Use. This is a post hoc analysis of a randomized clinical trial. So a little bit of background, like fentanyl and its analogs have significantly increased overdose fatalities in the last decade. Fentanyl is approximately 30 to 50 times more potent than heroin, has rapid distribution, and induces muscle rigidity, making it more likely to cause overdose than our classic opioids. Users often unknowingly ingest fentanyl and illicit drugs, increasing their overdose risk, although I'd argue today I think most of us just assume that this is in our kind of drug supply, and I think most drug users assume that as well. Standard urine drug tests cannot detect fentanyl, complicating early detection and intervention. Buprenorphine is our partial mu-opioid receptor agonist, and it's effective for treating opioid use disorder, although there's limited data on the effectiveness of buprenorphine and other medications like methadone or extended-release naltrexone in treating opioid use disorder when fentanyl is involved. So we kind of infer this data from previous trials in the heroin era. A retrospective study showed similar treatment outcomes for opioid use disorder patients using buprenorphine regardless of initial opioid type, so fentanyl or heroin. And so kind of this study is a phase 3 clinical trial evaluating buprenorphine treatment efficacy in opioid use disorder treatment patients, including baseline fentanyl detection. And it was kind of comparing the sublingual versus extended release formulation. It's CAM 2038 is kind of the drug name. It's kind of done under a brand name now, Brixaldi, that many of us are familiar with, if you're going to use a brand name. With ongoing urine monitoring of fentanyl levels. So basically, this is really kind of a post hoc analysis, kind of summarized looking down at kind of the fentanyl level use. The clinical question is, what is the effectiveness outcomes of sublingual buprenorphine naloxone compared with extended release subcutaneous buprenorphine injections in treating opioid use disorder when fentanyl is involved? So specifically looking at the efficacy of these drugs with kind of fentanyl use specifically. What do you think of that question, Sonya?
I think it's super important because, we've talked about before, I know I have and you have also had to change some of our practices to respond to the fentanyl epidemic. The people who are using fentanyl now are not in the same situation as people who were using like oxycodone or heroin 10 years ago when we started prescribing buprenorphine. So I've had to change some practice just based on my personal experience, but there has not been a lot of data to guide that. And so I'm super interested to see if my personal feeling that what I used to do that worked for heroin does not work anymore for fentanyl, to see if these protocols work for people who are taking fentanyl versus heroin in the same way, or if there really is a difference.
Yeah. So kind of method, study design. This is a post hoc analysis of a 24-week randomized, double-blind, double-dummy, active controlled, multi-center phase 3 study conducted at 35 U.S. outpatient clinical centers, and it featured 420 participants with opioid use disorder seeking treatment, and it ran between December 2015 and November 2016. Inclusion criteria was adults aged 18 to 65 with moderate to severe opioid use disorder seeking voluntary treatment, so voluntary only. Exclusions included recent opioid use disorder pharmacotherapy, so receiving a medication for opioid use disorder prior to the study, significant non-opioid substance use disorder, so kind of our polysubstance patients, although we kind of are going away from that terminology, and chronic pain patients requiring opioids. I will say kind of exclusion right off the bat, this does narrow this quite a bit from kind of my average clinic population. Outcomes of interest were UDS results, also self-reported illicit drug use. So they did a timeline follow back, which is pretty common for most of these trials. They did withdrawal scales using a CALS, SOS, and a VAS score. So kind of most of us are familiar with the CALS score, the clinical opioid withdrawal score. The SOS is basically similar, but it's subjective data. So a lot of people use this in a clinic for tracking. And the visual analog scale, just basically 1 to 10, how much they want to use drugs or feel the need to use them. They also collected data on self-reported adverse effects. So a little bit about the study design for the trial that kind of this came out of. So it basically started with a screening period, which was approximately 3 weeks. They looked for eligible participants who underwent screening for this inclusion criteria. Then started phase 1, and this ran from 1 to 12 weeks. And on day 1, participants presented an opioid withdrawal and received a test dose of oral sublingual buprenorphine, 4 milligrams. They were then randomly assigned 1-to-1 to group 1, which was daily sublingual buprenorphine, and they would kind of titrate this dose up to 24 milligrams daily. And then that group also got a weekly subcutaneous placebo injection. Group 2 got a daily sublingual placebo tablet, plus they got a weekly subcutaneous buprenorphine injection, which kind of was equivalent to 32 milligrams per week. They then had weekly visits for medication administration and assessment. They got a UDS, CAL, SOS, VAS, and a self-reported drug use was obtained at each of these visits. Phase 2 was weeks 13 to 24, and they basically continued the double-blind treatment that was offered in Phase 1, and they made sure that they transitioned the subcutaneous buprenorphine injections from weekly to monthly. So the second 12 weeks, you went from weekly injections to monthly or monthly placebo injections. And that kind of went up to 160 milligrams per month, or kind of a matching placebo dose. You had monthly visits at weeks 16, 20, and 24, and you additionally had kind of a randomly assigned visit for urine drug collection and self-reporting of a listed drug use. So you got random ones in there as well. Then there was a follow-up period for 4 weeks where participants transitioned to standard treatment. So everyone went to kind of sublingual buprenorphine. They did monitor during this period to assess ongoing outcomes and safety. They did this attention to treat statistical analysis with mixed models or repeated measures for kind of the post hoc analysis. What do you think of how they did that trial?
It was pretty good. I appreciate that it's randomized and blinded with a placebo. We don't see that as much with addiction medicine trials. I think it was long enough. It was for 6 or 7 months, so long enough to kind of see if it really was making a difference for people. The protocol is pretty good. The only thing that's different is I personally don't really use the weekly injections at all. So I wouldn't use that as part of the protocol if I were doing something like this in my office. But, I think it seems pretty good.
Yeah, I love the fact they had sham injections there too, because I think there's a huge placebo effect, especially kind of the more invasive the intervention, the more of a placebo effect. So I think that was really kind of a big strength here, right?
Yeah, for sure.
You're right. I don't quite get the rationale for the weekly. I know we've gone through this before, and I feel like I'm drinking the haterade. I don't really find a huge niche for that, but I know they got it.
Well, I've never tried it. I think it would be different if I had a clinic where I stocked the medication and people were kind of coming and going. But given that I have to order it, then it has to be delivered from FedEx, and I'm not even in my office every day, like trying to get a dose delivered every week for a specific patient seems like a lot of work, and they could just come in once a month. They don't want to come in every week either. So I don't know who these patients are who want to come and see me every week.
So is the trial valid? Bradbury Incorporated was the manufacturer of the depot drug. They participated in all aspects of the study, including design, data collection, management, analysis, data interpretation, manuscript preparation, review, approval, and decision to submit for publication. They did state that they had no role in data collection itself. So, this is a heavily industry-funded study, not taking anything away from it, but you have to realize that there's definitely some buy-in here in terms of outcomes. The authors disclosed relationships with several other pharmaceutical companies, so Camorus AB, Indivior, Alchemires, Pear Therapeutics, Opiant, Syneos, so lots of kind of ties to pharmaceutical companies with the authors. Again, kind of not taking anything away from this, but these are basically kind of like industry researchers, and this is industry research. The study was a post hoc analysis of a randomized, double-blind, double-dummy, active-controlled, multi-center trial, had 428 participants. So that's pretty nice, right? This is kind of we talked about, you can say that where was your kind of heart at for this study in terms of the funding, but actually this is really good, right? So this is not what we get for our other kind of studies that we cover here. So this is a large trial. It was like well designed. And even to go into the fact of doing like I said before, the dummy injection, I really think this was like a lot of effort was placed into making this a very valid, well-designed study, which takes money. The study included outcomes of interest, so kind of the VAS, SOS, CALs, personal recall. These are all basically pretty validated tools we use on a daily basis. We know they're kind of reproducible. And certainly, especially like the subjective opioid withdrawal scale, that's very kind of patient-centric, right? It's kind of how they perceive how they're feeling. I think I've always kind of been interested to see that sometimes there's a big discordance between the SALs and the CALs, but I think that, definitely the SALs will be the more patient-centric objective measure. I really enjoyed the fact that this paper was very easy to read and easy to interpret for me. I feel like I think I was after like a long week of working in the hospital. This was nice. It wasn't kind of complicated statistical analysis. It wasn't kind of robust data pools, and it was kind of a relatively almost a straightforward research paper that you would expect from like an RCT trial. So that was kind of really great here.
I'm sure the pharmaceutical company wants you to be able to understand it. I'm sure that's part of their goal, to write the paper in a way that's easy to read and easy for you to get the results out of.
Yeah, and that was appreciated. So a major limitation of the study was conducted in 2016. So it's coinciding with fentanyl's emergence in the market. And this was kind of potentially leading to unintentional intermittent exposure. So, they talk about the fact that like this was really the year or this time frame when it was starting to enter the market. So that a lot of these kind of subjects, they thought they were probably intermittently exposed to fentanyl. So it wasn't as opposed to like our current population, which is basically we assume of as continual exposure. So I think that's pretty valid kind of critique. And the authors kind of talked about that themselves. The study included data from diverse regions. So Alabama, California, Florida, Michigan, New Jersey, Ohio, Pennsylvania, and Texas. So this may not represent all drug markets in the US, but certainly it was a pretty wide net here in terms of kind of geographical distribution. Selection criteria would really probably limit extrapolation to, I think, my average clinic patient. And I guess this is a me issue, not the study issue. I do feel like a lot of my patients have secondary pain disorders or they have comorbid methamphetamine use, which is a real kind of like, I think, the fourth wave of our opioid epidemic. So the fact that those patients were kind of selected out of this, I think would limit a little bit of generalizability just to kind of my average clinic day. Baseline demographics indicated a more severe opioid use disorder in the fentanyl positive subgroups. That kind of indicates kind of a higher rate of additional substances like benzodiazepines and cocaine. So that could pose challenges in interpreting kind of treatment effects. So while they didn't have a substance use disorder, their baseline UDSs were a little bit more abnormal. So it could have been just a more sick population, if that makes sense. Any other thoughts, Sonya?
No, I think it was a valid study. And, you had said, and they had said that the timing of the study done in 2016, which coincided with, the emergence of fentanyl, might have led to some confounding, but it allowed for the, a secondary analysis to see how this drug really worked with fentanyl itself. So I don't know if that was really a true limitation. I think it was a very good study.
Yeah. What are the results? So participant characteristics, basically they were similar between the two groups. So 428 participants were randomly assigned, with 123 of these participants demonstrating baseline fentanyl use. The fentanyl positive subgroup had a mean age of 39.1. They were primarily white, 73.2%, and heroin was identified as the primary opioid in most cases, 84.6%. And the fentanyl negative subgroup, kind of mean age was again 38.1, so very similar. It was predominantly white, 76.4%, and heroin was identified as the primary opioid, actually a little less frequently at 65.2%, but these were very similar between the two groups at baseline. In terms of buprenorphine dosing, these were also relatively similar between groups. Mean dosing was comparable across groups, with most receiving anywhere from 16 to 24 milligrams daily of sublingual buprenorphine or that equivalent subcutaneous dose. So kind of not big dosing variations between the fentanyl positive and fentanyl negative subgroups in terms of symptom capture. Retention and treatment was also similar between groups. So there were similar completion rates between fentanyl positive and fentanyl negative subgroups, 60.2% versus 56.7% respectively. There was no significant difference between subcutaneous buprenorphine and sublingual buprenorphine. That was 62.5% versus 57.6%. So relatively similar once again. Safety outcomes, again, were similar between the two groups, with the only really meaningful difference being local site reaction in patients receiving the subcutaneous injection, where they had more episodes of subcutaneous swelling, inflammation, induration, but otherwise all other kind of safety outcomes were like insignificant in terms of their difference between the two groups, which makes sense. When you kind of look at kind of like further kind of diving into this in terms of any opioid use. So interestingly, the subcutaneous buprenorphine produced more favorable outcomes when you look at kind of baseline fentanyl users. So kind of the first outcome is opioid negative UDS sample. So fentanyl positive subgroup had lower opioid negative rates than the fentanyl negative subgroup. And that was 24.7 versus 34.6% with a p-value of 0.09. So that was statistically significant. So basically the subcutaneous buprenorphine group was more favorable for the fentanyl positive subgroup than the negative. Buprenorphine and naloxone had lower scores than subcutaneous buprenorphine as well in terms of kind of withdrawal scores, and that was statistically significant at 0.04. The mean percentage of urine samples negative for opioid in the fentanyl positive subgroup was 28.5% for subcutaneous buprenorphine versus 18.8% for the combination sublingual. And that was kind of an absolute difference of 9.6%. So that was not statistically significant. In terms of the mean percentage of urine drug screens negative for opioids in the fentanyl negative subgroup, it was 36.7% in the subcutaneous group versus 30.6% in the sublingual group, with a 6% difference, and that was not statistically significant, again, a p-value of 0.14. When they did this kind of mixed model analysis, the fentanyl negative subgroup, there was a significant treatment effect favoring subcutaneous buprenorphine, and that was statistically significant. In the fentanyl positive subgroup, there was also a statistically significant effect on time and treatment by time when you looked at kind of people receiving the subcutaneous formulation, and that was both statistically significant outcome. The percentage of opioid negative samples increasingly was notable in the subcutaneous buprenorphine group at week 5. So that was kind of the real point where the group kind of branched away. So that seems to be kind of the time frame to treat and get your benefit with the subcutaneous injections. When you looked at fentanyl use specifically, not just all opioid use, once again, kind of subcutaneous buprenorphine produced more favorable outcomes in the baseline fentanyl users than the sublingual formulation. So if participants negative for fentanyl at baseline, both treatment groups showed high rates of negative urine drug screen samples, so 82 to 97% with no significant difference between treatment groups. So that's kind of in your fentanyl negative baseline. Among patients with baseline fentanyl positive status, subcutaneous buprenorphine led to higher rates of urine negative samples for fentanyl or norfentanyl compared to the sublingual group, especially after that kind of week 5 in the trial. Summary scores indicated significantly greater percentages of urine samples negative for fentanyl with subcutaneous buprenorphine 74.6% compared to the combination sublingual formulation of 61.9%. That was about a 13% difference with a very significant p-value of less than 0.001. Similarly, percentages of urine samples negative for norfentanyl kind of mirrored that. It was significantly higher with the subcutaneous buprenorphine 61.3%. compared to the sublingual formulation, the 43.4%. That was an 18% difference, and it was very statistically significant with a p of less than 0.001, which makes sense since it's a metabolite. I wish I could show a graph here, but it really was interesting seeing kind of the positive subgroups by time. And you can really see that kind of week 5, there really was kind of a branching for this group that was fentanyl positive at baseline. From those that received the subcutaneous versus the sublingual buprenorphine formulation.
Yeah, those graphs in the paper are pretty nice. I'll put them on our social media if anybody wants to follow us or check us out on like Instagram or Facebook. You can see these graphs.
Yeah, I think that's the one thing sometimes lost in the podcast. I love the podcast, but because you listen to it in the car, but the pictures sometimes say more than I can say. But they are impressive where they start to diverge at that week 5. What did you think of the results, Sonya?
I mean, I wasn't super surprised given my clinical experience, but it's really nice to see the numbers just kind of laid out there. These people don't 100% mirror my patients, but the results are what I would have expected, I guess, which is good. It's nice to have the study confirm what you kind of feel might be true.
Yeah, so I will say that kind of spoiler alert, this kind of mirrors my clinical bias. I would say opinions bias as to kind of what I see on a day-to-day. So, as an addiction medicine doc, I basically give patients the choice. So I empower patients. Our first session, we often have like a counseling session where I talk about the different treatment options, kind of buprenorphine, either in sublingual or depot formulation and naltrexone. Most patients are pretty smart. They come in knowing what they want to kind of obtain. So really kind of I give them pros and cons and I let them select. I have had many patients in my practice that have kind of failed, quote, higher levels of care, where they were either kind of at a day program where they went every day or a methadone maintenance program and were still using and came to see me and we've used depot buprenorphine and they've done incredibly well. Surprisingly so, better than they did kind of in a very regimented methadone maintenance program, which has always kind of been very kind of surprising to me. I don't think that currently I tell people that what they should and should not do, although I do think that kind of just like this study mentions, I think that kind of more severe disease and kind of patients that are using ongoing fentanyl, which we kind of assume is the most common reason for continued relapse in today's current drug market, I think I would gently suggest that this may be more helpful for them than kind of the going to the sublingual formulation if they're open to trying something new. I think the only difference with this study is, like I said, I do have a lot of polysubstance patients. I also have a lot of patients with methamphetamine, chronic pain. It might not kind of mirror exactly, but I think when we're looking kind of in the silo at kind of the opioid use, it does seem that the depot buprenorphine probably has a niche for people that are struggling on the oral or sublingual formulation, and still using despite kind of optimal treatment and optimal dosing there.
Another thing I liked about this study, John, is that I often assume that the injectable buprenorphine works better for people who are struggling, not necessarily because it's different medically, but because it eliminates a lot of the issues with adherence to the treatment. Like, you don't have to do it every day. You can't lose it. It doesn't get stolen. You don't have to deal with the pharmacist. If your life is in chaos, the medicine is just with you at all times. You can't stop it. And so I thought that maybe that was why it was more effective for some patients. But with this being a, double-blind, placebo-controlled trial, it eliminates that part of it. And yet the injectable was still, it wasn't dramatically more effective, but there was still a trend towards the injectable being more effective. So I liked seeing that.
That was an interesting study. Definitely kind of a new piece of information for kind of treatment of my population.
So do you think this is going to change your patient care?
I think it's going to be very similar to what I currently do, although it kind of reinforces my bias that this is a very effective treatment for people that are struggling. And I think that while it's not going to change what I offer people, I think people should be empowered to make a choice about their own treatment. I do think if someone's struggling, I may kind of say that this might be more effective based upon our current literature.
Well, and I think that might change it for me too. Like, I didn't feel comfortable saying before, like, oh, the injectables work better. It's the same medication. It's doing the same thing. I really have told patients it's whichever you prefer, not which one works better. But I think I could start to say with this data that it might work a little better. Thank you for presenting that article, John. I think our listeners will be very happy about it. I did also want to share a little bit of talk back with our audience. So we got an email from a researcher named Price Mishner, and I hope that I'm pronouncing your name correctly. He's the lead author of the paper we profiled in episode 45 about urine drug screens, and that was a paper we really liked, and it sparked a lot of discussion among our colleagues at St. Max's. So he wrote us. He said that it was great to hear your thoughts on the article and the conversation it sparked. I appreciated your discussion of the limitations of the study and potential directions for future work. I would have liked to work with OTP retention and drug screening data directly instead of relying on surveys of OTP administrators, but unfortunately, we were limited by the data available. One of our main goals with the study was to start conversations about the risks, utility, and potential for stigma with urine drug screening in substance use care. So I'm happy that you found the article useful for starting those conversations. And we just want to thank you, Price, for doing this amazing research and for listening to the podcast. Your article definitely sparked some serious conversations. Yeah, thank you. If you're listening to this, we appreciate it. So thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included on a future episode, please send us your comments on social media, email, join our Facebook group, or you could just tell us stuff if you see us at work, around the hospital, or in the office. The links for all these things will be in the show notes. Our original theme music was composed and performed by Benjamin Kennedy. We got CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation, and have a great day.